Hello. Age-related macular degeneration is a disease which causes slow progressive binocular loss of central vision due to deterioration of the retinal pigment epithelium in the macula. Age-related macular degeneration, AMD, is a major cause of blindness worldwide. Currently, 1.75 million people are affected by advanced AMD. With an aging global population, 3 million people could be affected by 2020. Age-related macular degeneration is typically classified into two clinical forms, non-exudative or dry and exudative or wet. Non-exudative or dry is associated with the presence of drusen, deposits of extracellular material beneath the retinal pigment epithelium, RPE, and with the absence of visual loss early in the disease. Dry AMD often progresses to retinal atrophy and central retinal degeneration with associated loss of central vision. Exudative, or wet, is associated with pathologic choroidal neovascular membranes, CNVM, developing under the retina. Age-related macular degeneration is the third leading cause of blindness worldwide. AMD occurs bilaterally, but it is often asymmetrical. The risk factors for AMD are gender, female, age, over 50, ethnicity, Caucasian, light-colored irises, smoking equals 2 times risk for smokers, genetic component in advanced AMD. Symptoms of AMD: impaired dim light night vision, metamorphosia, central scotoma. Patients with non-exudative AMD present with the following: drusen, usually confluent with significant pigment changes and pigment accumulation in the posterior pole. Retinal pigment epithelium often appears atrophic, with easier visualization of the underlying choroid plexus. On the left photo, focal atrophy seen in en face image, drusenoid pigment epithelial detachments seen on retinal pigment epithelial topography. On the right photo, transmission defect from geographic atrophy over drusenoid pigment epithelial detachments. Patients with exudative AMD present the following: subretinal fluid, retinal pigment epithelial detachment, subretinal hemorrhage, subretinal lipid deposits, occasionally. On the image, you can see the large serous pigment epithelial detachment and subretinal fluid. Non-exudative, dry AMD is characterized by slower, progressive visual loss over decades, relative to exudative, wet AMD over months. Approximately 10 to 20% of patients with non-exudative AMD eventually progress to the exudative form. Currently, there is no available approved drug treatment of dry age-related macular degeneration. However, the Age-Related Eye Disease Study, AREDS 1 and 2, have shown that supplements decrease the risk of progression to advanced AMD, either dry or wet, by 25% to 30%. Daily multivitamin: zinc, copper, vitamin C, vitamin E, lutein, zeaxanthin. Smoking cessation: dark green leafy vegetables, for example, kale, chard, spinach, Brussels sprouts. Fresh fish, for example, salmon, mackerel, 3 times a week, not fried. Supplemental omega-3 has no additional benefit. No benefit if better than intermediate dry AMD. In wet AMD, vascular endothelial growth factor, VEGF, is a key mediator in ocular angiogenesis. For this reason, particular attention has been focused on the development of pharmaceutical agents to block or neutralize VEGF expression. Intravitreal anti-VEGF. Pegaptinib, Vacugen, first generation. Bevacizumab, Avastin. Ranibizumab, Lucentis. Aflibercept, Eylea. Treated monthly, PRN, as needed, with monthly follow-up or treat and extend. Approximately 1/3 improve vision, 1/3 have stable vision, and 1/3 have worse vision with anti-VEGF treatment.